So we're going to talk about the airway A&P, and we're going to talk about the mechanisms of oxygenation and the mechanisms of ventilation. We're going to get into a little bit of acid-base balance. You guys should be pretty firm foundation-wise with acid-base as far as respiratory acidosis and metabolic alkalosis. We're going to look a little bit more on blood gases, arterial blood gases. Anybody, when you did respiratory clinicals, y'all see them drawing the blood from their arteries and all that? So we're going to look at kind of what we look at when we draw blood gases so that we can get a little bit better understanding on exactly what makes respiratory acidosis. And then by understanding that, then we'll understand respiratory or metabolic acidosis or metabolic alkalosis. But before we get to that stuff, we really need to, just like yesterday, we need to go back to the basics. And other than with cardiac arrest, airway and breathing, even on the most basic level, is going to be the most important aspect of any patient assessment and any patient management, right? The only time that we don't manage airway and breathing first if it's somebody confirmed pulseless and apneic, and we're going to start doing what?
CPR.
Compressions. Yeah. So at this point, we should know that the human body needs a constant supply of oxygen. Two organs really demand it. And what are they? The brain and the heart. And they both kind of go hand in hand with each other, and so when one starts being deprived of oxygen, the other one's going to be deprived of oxygen. Oxygenation and ventilation is simple in the fact that ventilation is a mechanical process of breathing air in. Oxygenation or respiration is the chemical process of diffusing oxygen and CO2 across the respiratory membranes and transporting it through the rest of the body. We know that the respiratory system, its sole purpose, the pulmonary system, is to bring in oxygen and get rid of what? CO2. On our most very basic level, we want to bring in oxygen and get rid of CO2. So at this point, think about oxygen being the fuel and CO2 being the waste, right? We bring in oxygen, then we get rid of CO2 because we don't need CO2 in the body after the oxygen has been processed. The vital organs cannot go very long without oxygen, right? Duh, we know that. How long does it take for your brain cells to start dying if they go without oxygen?
8 minutes.
So we're looking at probably complete death in 6 to 8 minutes, right? But we're going to start seeing some pretty bad deficits. I mean, early on into 3 to 4 minutes, right? If you can think about the average person probably can hold their breath for about 45 seconds before the body starts saying, hey, you need to start breathing again, right? Because the body's already recognizing that it's doing without oxygen. What are your early signs of decreased oxygen?
Cyanosis, decreased
Early
respiratory.
signs. Okay, maybe shortness of breath. But how about just anxiety? How about just starting to see some changes in mental status? Think about how anxious you feel if you go running around a track or walking up the stairs or something like that. Think about just how you feel when you start when the amount of oxygen that you're used to getting starts getting reduced, right? This is going to be paramount in any critical situation, is managing that airway. And when I say managing the airway, is that going to just be giving them supplemental O2 on a nasal cannula? Or is that just going to be intubating them to provide a definitive airway? No, it's not. It's going to encompass the whole aspect of the respiration ventilation process. That's why you have your A and your B. right? Your airway is going to be looking more at the mechanical aspects. Is the tubes open? Are we able to get oxygen in and out? And then the breathing aspect of your assessment is going to be looking at the respiration processes, right? Are we getting oxygen to the rest of the body? Without proper oxygen, the body's going to fail, the organs are going to start shutting down, and then we're going to start having a lot bigger issues. So as paramedics, we're going to have to be able to detect early and recognize the subtle signs. If somebody is in respiratory failure, that's going to be very easy to identify, right? If somebody's in later signs or the later part of respiratory distress, that's going to be pretty easy to identify. But if somebody is early on not oxygenating well, what does the body do? It tries to compensate. So they may have some type of deficit going on inside of their body, but the body is compensating. But the body only compensates for so long. So that's where we're going to have to look at the bigger picture and understand really what's going on. Why were we called to the scene? And by using critical thinking aspects, we're going to have to say, hey, this patient has got this going on with them. So I'm thinking, hey, there may be something going on with their perfusion status. Even though right now the body's compensating, let me go ahead and jump on that early and go ahead and start providing them with oxygen so that we can kind of halt that process, right? Respiratory distress, if not managed properly, quickly leads to what? Respiratory failure. Respiratory failure, if not managed quickly leads to what? Respiratory arrest. Respiratory arrest, if not managed properly, eventually leads to what? Cardiac arrest and death, right? So, as paramedics on the scene, we want to figure out where they are in that process. If they're having breathing difficulties, if they're having respiration difficulties, we want to figure out where they are in that process and try to start reversing it. How do we reverse respiratory distress? By managing their airway and their breathing, right? If they're having issues with respiration, if they're having issues bringing oxygen in, then we're going to give them supplemental oxygen. Or we're going to open their airway. We're going to provide them with a definitive airway. The respiratory system can be managed fairly easy just by giving them oxygen. Now, if they've got other underlying issues going on, then those issues may have to be managed too, but we're always going to start with our A and our B, right? What are some other issues that could alter oxygenation? All right, foreign body obstruction. So that's going to alter ventilation, right? That's going to give you issues with the mechanical process. What about internally? What? Okay, edema, pulmonary edema. So pulmonary edema is going to really have an aspect of both the ventilation and the oxygenation. It's going to impinge the ventilation because it's going to fill the alveoli with fluid, which in turn is going to keep the oxygen from getting across the barrier, right? Acidosis, alkalosis, shock. All these things internally, if they've got underlying issues, we may not be able to just reverse their respiratory issues just by doing airway and breathing management. We may have to move on, right? So our first steps in airway management, and I know that this is all elementary to you guys. I mean, this is EMT stuff, but we need to make sure that we're grounded on this. And our first steps is always going to be what? Make sure that airway is open. If that airway is not open, then it's not going to do us a bit of good to hook them up to 15 liters non-rebreather mask or put a CPAP on them or try to ventilate them if their airway is not open. We need to treat obstructions. And by treating obstructions, how do you treat an obstruction? You get it out, right? You get it out. And then, of course, their ventilation, oxygenation status. What is going to really give you a good picture of their ventilation and oxygenation status?
Your pulse oximetry and your CO2.
All right, pulse oximetry, end-tidal CO2. If we've made it that far, what about just general impression, just looking at a patient? Skin color, mental status, peripheral pulses, central pulses. All the things that we talked about yesterday, that you can tell how the heart's functioning mechanically by doing pulses and looking at skin color and just your overall impression of the patient. The same thing with the oxygenation. And one of the reasons why I'm glad that I'm doing the cardiology and the pulmonary is because I can kind of combine the two, because really and truly they go hand in hand, right? Even though they are their own systems, they're not going to work properly without the other, right? So, when we move on into the anatomy of the airway or the respiratory system, where does your anatomy start for your respiratory system? Your mouth and your nose, the holes that bring it in, right? And so really it is a pipeline, it's a set of plumbing, if you will, that has specific structures, and each structure has a specific job, right? I mean, think about your nose. As I've gotten older, I've noticed I have all these little nose hairs that are hanging out and all that. I haven't made it to the ear hair yet, but the nose hair is there. What is the point in nose hair? To filter, right? Think about this. The lining of the respiratory tract needs to be filtered, right? The lungs, we need to have that filtration. So we've got the nose hairs at the most external part. But as we go into the respiratory system, what's on the side walls of the cilia? So just think of the cilia as kind of like the nose hairs of the respiratory system, right? Of the internal respiratory system, because they're all there to try to filter. The anatomy of the respiratory system, or of the, well, let's just say the respiratory system. Each structure has a specific function. And if those functions don't work, we do not have the mechanical process of ventilation, right? Think of it just as plumbing. Think of it just as tubing. And if we get something that's blocked, if you've got a hose, or in the South, a hose pipe, that you have something blocking, what's going to happen? It's going to get stopped up, right? What if that hose starts denosing a little bit? Or what if that hose starts clamping down on itself a little bit? You're going to have even more issues with the water going through. Same thing with the airway. The diaphragm. Somebody explain to me how the diaphragm is part of the anatomy of the airway.
So it pulls the air into your lungs.
Right, so the diaphragm separates what from what?
The thoracic cavity from the abdominal cavity.
Alright, the thoracic cavity from the abdominal cavity. The diaphragm is a muscle, right? Is the diaphragm a voluntary or involuntary muscle? What'd you say? It's both, right? Up until this point, you guys have just kind of been sitting here just breathing without thinking about it. Now that I've mentioned it, you're going to think about breathing for the next minute or two. So you can actually make your diaphragm contract to bring in air, right? And you can force that air out, right? The diaphragm, I always like to use the example of a syringe. Think about a syringe. I wish I would have brought one up. Think about a syringe. So you've got your stopper and you've got your syringe, right? So think about the syringe as being your thoracic cavity and the plunger being your diaphragm. What happens when you pull that syringe back? It creates negative pressure and it brings air or whatever you're trying to bring in. What happens when you push it up? It forces it out, right? And that's kind of the way that the diaphragm works. When it starts contracting and pulling down, it creates negative suction or negative pressure, which brings air in. What are your accessory muscles of breathing? Your sternocleidomastoid. Where are they at? Right there. Also your intercostals, right? Your diaphragm can be considered an accessory muscle. Think about belly breathers. Folks that are having trouble breathing, the abdominal muscles can be accessory muscles if your diaphragm's failing and you're actually having to use your abdomen to breathe. That happens a lot in what population? Peds, kids. That's right. That's right. And then really all the mechanical processes, they can't really function unless they've got somebody telling them what to do or something telling them what to do, right? And what tells it what to do? The nervous system, right? So just real quick, we're going to look at this and look at the airway, and then we can move on. So just like we said, the airway starts externally in the nose, in the mouth, then it goes into this little part right here. What's this called? Alright, what's it called when it gets down below here? The hypopharynx, right? What's this big old thing right here that could occlude your tongue? Can you swallow your tongue? Nah. Alright? What is this little cavity here called? Alright, so you got the nasopharynx, and then what's this up here behind the eye? Your sinus. I always love it when folks say, I got sinuses. This pollen's giving me sinuses. Well, it wasn't the pollen that gave you sinuses. You may have a sinus infection or a sinus inflammation. Alright? So as we go on down, what's this structure here called? The trachea, right? What surrounds the trachea? The cartilage? What's the point in the cartilage surrounding the trachea? Give it structure, right? What's the thing that kind of hangs out right here on most dudes, some women? Adam's apple or the thyroid cartilage, right? Alright? What's this little place right here called where the trachea kind of ends and then it starts breaking off? Carina. Yeah, the carina. And then the branch on the right is called what? The right main bronchus or the right main stem. And the one on the left is the left main stem, right? Now, what's something for us to remember, especially now that we're going to be intubating, about that right main stem bronchus? Right. So anything that we force down here is going to follow the path of least resistance, right? Now this isn't the best picture. I've got other pictures, but so the left main stem, it kind of goes more of an angle. And the right main stem, it kind of is more straight. So if we're putting a tube down somebody, is that plastic tube going to bend and go to the left? No, it's just going to follow the path of least resistance to the right. So, without ever being taught anything about intubation in this class, where do you think we want the end of the tube to hang out? Right there, so that it's going to ventilate both sides. Alright? So then, once we get past the main stem bronchus, we have these things called what? So, the bronchioles, and then they go on down to smaller ones called the terminal bronchioles, and then at the very end of the bronchioles, we have these air sacs called what? The alveoli. The alveoli is covered by pulmonary, capillaries, and arterioles, right? Because that's where what occurs? Gas exchange. Gas exchange. So, your upper airway is going to be all the structures above the vocal cords. Then your lower airway is going to be below the larynx. What's going to be important about the larynx in this class? That's our landmark. We're looking for those pearly white gates. And they really are pearly white if it's a pretty healthy person or a person that hasn't smoked. The pharynx, of course, extends from the mouth and the nose, or from the nose and the mouth to the esophagus and the trachea. And you got your naso, your oro, and then your laryngopharynx. Your upper airway. So here's the problem with the tongue. The tongue is just one big what? What controls muscle control? Or what controls muscles? The nervous system, right? If somebody has a depressed nervous system where they're not able to manage their airway, are they going to be able to manage their tongue? No. No. We'll get to this other stuff in just a minute. So the nasal pharynx receives the air from the nose and is formed by the union of facial bones. Y'all remember when we were talking trauma, like your Lefort fractures and all that kind of stuff? So this could be the area where that affects, that's why it may affect your breathing, because that's really what makes the nasopharynx, is this formation of all the bones, right? So if we have a discrepancy in those bones, if we have a problem with those bones and now we've got a big hole or a big fracture, then we're not going to be able to create the pressure that we need to ventilate, right? And we talked about the cilia and the ciliated mucous membranes. Snot. Gross, right? But what is the purpose of snot and mucus? Okay, so it may help with some of the warming and humidification, but it's really to be that what? It's like that Venus flytrap, right? Or that fly trap. It catches all that nasty stuff, right? And so that's why snot, a lot of times, it's yellow or brown or green or whatever. It's because it's catching all that nasty stuff that you're either breathing in or that's hanging out in your sinuses and your nose. When you get sick, you create more mucus because you're sick and you've got all this bacteria, all this pathogens and stuff. So that's why you have so much snot and all that. When we're getting ready to manage an airway, what's going to cause more of a problem? A lot of mucus or vomit? Probably vomit. Anybody get a chance to help when you went through your respiratory clinicals to help with like ET tube management, like cleaning the mouth and all that stuff with the ventilator and stuff? It's nasty, ain't it? Just all that slob that comes out and everything. Well, anytime in the mouth or the nose, anytime there's anything that will rub against these mucous membranes or that will cause inflammation of these mucous membranes, and ET tube being one of them, it's going to make those mucous membranes create more snot or more mucus. The septum, the nasal septum, is divided. It's what makes your nose have two different passages. What kind of problem do you think a deviated septum could cause? What? Okay, putting in an MPA because it may constrict that area. A person with a severe deviated septum may not be able to breathe very well out of that side. Also, we're going to learn how to intubate people through their nose. All right? So all this stuff that we're talking about here, even though, yeah, we've already seen it before, is going to be important because these kind of terms are going to come back up when we start talking about intubation and intubating somebody nasally and all that. Your sinuses, they're what's going to kind of trap stuff. That's where your snot hangs out, right? That's where that stuff that's filtered out, it kind of hangs out. And then when you have like sinus inflammation or sinus infection, that's why that stuff just starts dripping out because your sinuses get so full. What separates the nasopharynx and the sinuses from the brain? Just a thin layer of bone, that basilar skull. Just a thin layer of bone. So if you've got a basilar skull fracture or some type of facial fracture, you may start having CSF come through that area. And that's stuff that's going to be important to locate or to notice when we're getting ready to intubate somebody. The oropharynx. The oropharynx is a little bit harder to manage than the nasopharynx. All right, so the nasopharynx this is somebody's nose. So the nasopharynx is going to go up and then it's going to pretty much come straight down, right? The oropharynx, and it's nowhere near as big. The oropharynx, we're going to have this big opening before it goes down. And it connects. What? Really? Okay. I was kind of looking at you when I was drawing up. So what's going to happen in the back of the mouth, the oropharynx? What can happen? If somebody doesn't have that nervous control over their muscles, over their fluids, all right, so the tongue can lay over, right? It can obstruct. Also teeth, if they've had trauma, or if they're bleeding, or if they're vomiting. All that stuff can come back up and just kind of hang out right there. So it's going to be very important to suction. The tongue is attached to the mandible and the hyoid bone. And out of any kind of obstruction, your tongue is going to be the most common cause of obstruction. Your palate. You've got your hard palate and your soft palate. It separates the oropharynx and the nasopharynx. Your hard palate is the front, right? And then your soft palate is where it gets to the back and it's soft. Where could we run an issue with further damaging a patient if we're trying to intubate them?
Stick the blade, mess up their soft palate.
If we get in there and start messing around with a tube and blades and all that kind of stuff, we could really do damage to that soft palate and cause a lot more bleeding. And then the palatopharyngeal arch is the entrance to the throat. So that's where the palate ends, and that's where the throat or the pharynx begins. What is an issue, a congenital issue with the palate? Cleft palate. There's some kids that are born without a hard palate or without a soft palate. So then you've just got one big cavity right there. Most of the time they get it fixed. Your tonsils. What system are your tonsils part of? So they're part of the lymph, part of the endocrine system as well. What is really the main function for your tonsils and your adenoids? Yeah, they're really an immune thing. They don't have a huge role. I mean, it's not life or death if you have them or not. But if they become infected or inflamed, then you have to get them out. When adults start having tonsillitis, it could really be a very bad deal for them. That's why they usually try to identify it in kids and get it out. But if an adult gets tonsillitis or issues with their adenoids, those things can swell up and actually occlude their airway off. moving on into the lower airway. So the main purpose of the lower airway is to provide a pathway to get oxygen down, right? That's really what it's for. It's for respiration. But again, it is tubing, it is plumbing that can become occluded. Externally, it extends from the fourth cervical vertebrae to the xiphoid process. Where's your xiphoid process? That little thing that kind of hangs off at the end. And then internally, it spans the glottis to the pulmonary capillary membrane. Where's the pulmonary capillary membrane? Yeah, the alveoli. That's where what occurs? At the pulmonary capillary membrane. Gas exchange. The larynx, again, is where the upper airway ends and the lower airway begins. The thyroid cartridge is formed by two plates from the laryngeal prominence. The laryngeal prominence is your Adam's apple. It's going to be very important. It's going to be very important for you to be able to easily identify where the thyroid cartilage is, where the cricoid cartilage is, and then the membrane in between the two, the thyrocricoid membrane. Because you're going to learn how to do needle cricothyrotomies, which is putting a needle in somebody's throat to provide an airway. So you're going to have to learn how to feel that quickly, because I don't know, I'm sure that not everybody's in here is planning on doing some type of critical care paramedicine or something like that, helicopter flight or something like that. But if you plan on doing it, and even in the state of Alabama, they're starting to introduce a lot more things for field medics to do. You're going to have to be able to identify these airway structures very quickly in the field. So that's why we go ahead and talk about them and where they're at. If you look back in your book to that picture, you'll notice that the thyroid cartilage is kind of a shield shape. All right, page 714 in your book if you got it. Is formed into a V shape by two plates. Do women have thyroid cartilage? Yes, they do, but it's not as prominent in women as it is men. If we're trying to locate this, what do you think could give us issues? Obese people, or people with short, stubby necks. You know, people with turtlenecks, right? Don't have much of a neck at all. And then the thyroid cartilage is directly anterior to the glottic opening. What's the glottic opening? The vocal cords, right? The cricothyroid membrane is a ligament between the thyroid and the cricoid cartilage. I know this stuff is boring. Y'all stick with me, because we're going to get to a lot more fun stuff in the weeks to come. We're going to get our hands on stuff and all that, but we got to be able to identify these structures. So the cricothyroid membrane, like I said just a minute ago, except I said it kind of backwards, is where surgical and non-surgical needle cricothyrotomies are going to occur. So even if they're in the hospital and they're putting in a trachea, this is where they're going to put them in at. So you've got to locate this, and you'll learn how to stick a needle in there to create an airway for them. It lies inferiorly to the thyroid cartilage and forms the lowest portion of the larynx. And then it's the first ring of the trachea. Remember those rings we talked about, those cartilage rings? So that's the first ring, and it's a lot bigger ring. If you don't have your book, look on with somebody. But right here, if this is the thyroid cartilage, this is going to be your cricothyroid membrane. So that's where you're actually going to create a surgical or a non-surgical needle airway. The glottis. So, when we intubate somebody, this is what we're looking for. it's not always going to be as easy to find. One of the issues is that everybody's anatomy is different. Just like your fingerprint's different, the way things are kind of sitting in your body is going to be a little bit different than your neighbor's. That's cool. There's a couple of things that go with it. You've got true vocal cords and false vocal cords. Your true vocal cords are going to be usually pearly white. They're going to be pretty easy to identify in them. As we get into intubation, I've got some videos and things that I'm going to show you. Then you've got your false vocal cords that connect your true vocal cords. How do you talk? What causes your voice? Yeah, the air, the vibrations. So higher pitched sounds, woo, that's going to cause your vocal cords to vibrate a lot quicker. Lower sounds is going to cause them to go a lot slower. Your vallecula, this is going to be another landmark that you're going to look for whenever you intubate. So your vallecula is pretty much a pocket between the bottom of your tongue and the epiglottis. And it is an important landmark for intubation. If you're taking notes, highlight that, write it down or whatever. It's going to be an important landmark for ET intubation. When we start learning about the different types of blades that we use to intubate, the vallecula is going to be very important for one of the types of blades that we use. Then you've got this arytenoid cartilage, posterior attachment of the vocal cords. These are going to be guides for your ET intubation as well. Your piriform fossa, these are two pockets of tissues. When you see something anatomy terminology, the word fossa usually means what? Like some type of opening or pocket. So when you see these terms, just think openings. Now these are going to be openings that sometimes airway devices may go into. And if they go into them, then we're not going to be able to provide oxygen to the lungs, and we're going to have to identify that. They're on the lateral borders of the larynx. One way to identify if airway devices are inadvertently inserted into there is that sometimes there will be a tinting of the skin under the jaw. So these pockets are kind of down towards the back here, and if it goes into that inadvertently, then you may see that tube trying to poke out through the skin there. All right. When the airway is stimulated, we've got a defensive reflex called a laryngospasm. If the body identifies something as foreign going into the airway, it's going to inadvertently cause a laryngospasm. Why?
The body doesn't want that to.
Right. Pretty much the body doesn't want anything foreign going down its throat, right? Where is this going to cause a problem for us? When we're trying to insert an airway. Remember when we were talking about respiratory diseases, or if you learn respiratory diseases for pediatric patients, what are a couple of those respiratory diseases, especially that you may see this type of year, that could cause severe laryngospasm? All right, RSV, croup, epiglottitis, all those kind of things. You got a kid with an upper airway infection, you don't want to go down there messing. If you got an adult with some type of upper airway stuff, you want to have the most skilled paramedic trying to intubate unless you're doing RSI, which will paralyze everything. A lot of times a laryngospasm will only last a few seconds and then it'll open up. But here's the problem with that. If the body's already identified something which is going to cause a laryngospasm, it's already going to be on guard and it may continue to cause that laryngospasm. Okay? So your big tube for entry into the lungs is your trachea. Begins at the cricoid cartilage. The cricoid cartilage is the first ring, right? Remember the first ring of the trachea. That's where the actual trachea begins. So what was that little membrane or that ligament that was between the thyroid and the cricoid cartilage? Yeah, the cricothyroid membrane, right? So it descends down to the midline of the neck and chest to the 5th or 6th thoracic vertebra. Now, when it descends, if we're looking at a patient that's been in a trauma, if it's not midline, that's a uh-oh, right? That's a problem. Anytime you see a trachea that's not midline, they may have some type of traumatic injury going on. And then the esophagus lies posterior to the trachea. And when we're managing airways, we need to try our best to keep that esophagus closed off, right? Because, why? Yeah, we can aspirate. It's usually about 10 to 12 centimeters long. The place where it ends is called the mediastinum, or it ends in the mediastinum. And that's your space between your lungs, right? That's where it goes into the mediastinum. That's your space in between the lungs, in the middle. Mediastinum also contains the trachea, the heart, the great vessels, and portions of the esophagus. The cartilage rings that are around the trachea, are they completely round? No, they're a C-shape. Why do you think they're a C-shape? Right. The shape of it aids in swallowing in the esophagus. If they were a complete round shape, that's going to compress onto the esophagus. And the esophagus is already a hollow tube, right? The trachea then divides into the right and left main stem bronchus, right? We've already talked about that. The trachea and the main stem bronchi are lined with goblet cells, cilia, beta-2 adrenergic receptors. Your goblet cells, what do? They create mucus. They secrete a sticky lining that traps the potential contaminants. So that your mucus, your throat snot. What's the cilia do? So they're there to help filter, but they move. They help with movement. They help get that junk up, right? That's why a person that has been a chronic smoker for years, that starts taking the cilia out. Smoking will eliminate the cilia in your throat, and folks that end up with like emphysema, they can't cough that stuff up. You can hear it rattling in their throat, but they can't cough it up because they don't have the cilia to help them get it up. And then beta-2 adrenergic receptors. Ooh. Beta-2. Alpha and beta. Alpha and beta. This is where the beta-2 is going to be more important. Remember we said that the beta-2s yesterday, the beta-2 receptors really don't play a huge role in the heart, because beta-2 are more for the lungs. If I give a beta-2 sympathomimetic, a selective beta-2 sympathomimetic, what am I giving? Some type of bronchodilator, albuterol or Proventil or something like that. So what does beta 2 adrenergic receptors do? What does the beta 2 do? It bronchodilates and vasoconstricts. Your lungs. You've got 2 lobes on the left, 3 lobes on the right. What's the point in having 2 lobes on the left?
Because you have your heart's over there.
Yeah, because your heart's over there, so you need to have the little place for your heart to rest right there. The lungs, they branch off, remember, into the bronchioles. And then the alveoli are right here, right? And then what occurs at the alveoli level? Gas exchange. The lungs, are they hollow organs? No. They're not like your stomach that you can just take something in and they fill up. Where does the air go? Yeah, it goes down the bronchioles and then it goes into the alveoli. That's your air sacs right there. So your lungs don't necessarily just hold the air in. It's the alveoli that's holding the air in, right? This entire mass of tissue is called the parenchyma. And it consists of the smaller bronchi, the bronchioles, and the alveoli. The lungs can hold approximately 6 to 7 liters of air. Do you breathe in 6 or 7 liters of air each time? So what's going on with that air? Just kind of hanging out, right? The lungs are covered with a inner and outer membrane. What is that membrane called? The visceral and the parietal. The visceral pleura, or the visceral membrane on any organ, is always going to be very close to the organ, and the parietal is always going to push away. That's the way I remember it. The visceral is very close. The parietal pushes away. What's in between the two? Okay? You've got the pleural fluid and surfactant. What does that do? It aids for what? Yeah, movement, right? Expansion and constriction. It decreases friction during breathing. So, skin on skin, or any body organ, or any body other than fluid on another body part, creates friction, right? Unless it's lubricated. That's even with the inside of the lungs. And then you can have issues where you actually lose that pleural fluid, or it decreases, and then you start having a lot more friction. Alright? And then it causes a lot of pain. Anybody ever heard of pleurisy? That's what that is. That's why it hurts to breathe so bad, because it's just those two microscopic layers rubbing on each other, and they don't have that fluid. The bronchi subdivide into bronchioles. What type of muscle are they made of? Smooth muscle. Then they're aligned with the beta 2 adrenergic receptors. So not only does it dilate when stimulated, but it can, the beta 2 receptors, when we give medication, we're wanting to stimulate the beta 2 receptors to cause bronchodilation, right? But the sympathetic nervous system, because of it being smooth muscle and having those adrenergic receptors on there, it can tell it to bronchoconstrict or bronchodilate. Alright? Just like the sympathetic nervous system can tell the vessels to vasodilate or vasoconstrict. You follow me? Does that make sense? So, when would the sympathetic nervous system tell them to constrict? Yeah, some type of anaphylactic reaction, or if the body's just recognizing we're breathing in some harmful crap, right? And so again, the alveoli, they're balloon-like clusters, very small air sacs, and this is where the functional site of gas exchange occurs, from the alveoli to the capillaries. The alveoli are lined with surfactant. Alright? Surfactant is a phospholipid compound. I just want you to know that the alveoli are lined with surfactant. What does surfactant do? What? Okay, so it helps keep it from collapsing, but it also helps it to expand its surface area, right? Because what does a balloon do when you put air in it? It expands. The same thing with the alveoli. It provides for that lubrication for it to increase its surface area. Just like a balloon. When you blow a balloon up, when it's deflated, it's small, right? But as we're adding air into it and it's starting to get bigger and bigger, we're actually increasing its surface area, or its mass, the amount of space it occupies. That's what the surfactant does. It helps the alveoli to expand the amount of space that it occupies so that it can fill with oxygen. Does that make sense? When we're managing the airway, we need to be able to identify all these processes and all these areas of the chest, because each one of them, we may have something different that we need to identify it for to do. So on your sternum, we want to identify the body of the sternum, because that may be where we're doing compressions. We want to identify where the xiphoid process is, because we don't want to do compressions over the xiphoid process, right? The costal angle. The costal angle is just that angle where your ribs end. Alright? If you got somebody in respiratory distress, you may be looking at this to see how much they're using their accessory muscles, their abdominal muscles, to breathe. This would be a good indicator right here. Alright? We'll talk about the angle of Louis and all that later on. Okay. So we've gotten on through just the basic anatomy and physiology of it, or the anatomy of it. So now we're going to talk more about the physiology of breathing. What time is it, somebody? Okay. Y'all need a break, or y'all good to keep going? Huh? Alright, you said it was 10:25? Okay. Be back at 10:35.